On April 8, 2026, the panel of expert pulmonologists gathered in a virtual roundtable to discuss how they're using CyPath Lung, a non-invasive test using flow cytometry and AI as a tool to increase their clinical confidence in managing next steps in care for individuals with small pulmonary nodules who may be at a higher risk for lung cancer.
My name is Dr. Gordon Downey. I'd like to thank BioAffinity Corporation for providing this platform for our audience and for our panelists. So I'm a first-generation interventional pulmonologist. I trained at UNC Chapel Hill. I've mostly published in photodynamic therapy, early lung cancer diagnosis, and bronchoscopy education. I joined CyPath as their chief medical officer about 12 months ago and have had a wonderful year working with them and talking about our product. We're fortunate tonight to have a wonderful expert panel who have significant experience in this arena and have added CyPath Lung to their clinical practice algorithms. We have Dr. Gouda joining us from Fort Worth. He's an interventional pulmonologist and specializing in robotic bronchoscopy, airway stenting, and minimally invasive diagnostics in lung disease. We have Dr. Michael Nicholson joining us from Robert Wood Johnson practice in New Jersey. He trained at Temple and he does pulmonary and critical care. And lastly, we have Dr. Greg White joining us from Texarkana, Texas at St. Michael's Hospital. He specializes also in pulmonary and critical care. He assesses about 500 pulmonary nodules every year, so very expert panel. Every clinician who's joining us tonight is in a unique region that have different ways of defining the components of pulmonary nodules and the clinical challenges that assessing lung cancer, diagnosing lung cancer, and assessing pulmonary nodules. As an interventional pulmonologist, at one time the vice chair of the ACCP Committee on Intervention, and now as a practicing pulmonologist and CMO, I have heard from clinicians all over the country about the challenges of dealing with pulmonary nodules. Dr. Gouda, I'd like you to talk a little bit about how you receive your referrals. Do you receive them from hospital systems, from internal medicine docs, family practice docs? How do you receive these referrals, and how are you told, or how are you directed by those referring people about your next step in the process?
A lot of our clinical practice is kind of directed by the presence of oncology. So we have about 34 different oncologists that feed into our practice. And essentially, these oncologists, they are looking for answers. So our clinic is essentially a procedurally driven clinic because these patients have already been seen by oncology. Either you're looking for metastatic disease or you're coming in with a higher clinical gestalt than you typically get from a primary care physician or a pulmonologist. So our clinic is pretty much directed by that kind of a burden. From the community also, we just reviewed some of our numbers and we are seeing an increasing awareness in the community about screening.
Dr. White, we're both from Northeast Texas and we've been colleagues for a long time, and we've talked about our individual clinics, and I know we've discussed anxiety, patient stigma, patient nihilism, and how anxiety and fear affects the process. You want to touch on that a little bit?
Absolutely. You know, our patients, I imagine, like most patients that live in a community, they're all a little headstrong and stubborn. Most people here smoke. I still have an ashtray outside my front door in my office because I got tired of people throwing cigarette butts in my bushes. They know that they literally smoke and there's a risk associated with it. But they're like, I'm fine. It's not bothering me. But somehow they get a CAT scan, they can find a nodule, they may cough up some blood. Oh, it's okay. The blood was stopped, or it's still coughing up blood, and they'll just kind of kick the can down the line for a little bit. CyPath gives them a kind of a piece of ease. Just like it's negative, or if it's positive, we should probably do something sooner. So that's kind of upfront with CyPath. The other thing that I kind of use CyPath a little bit downstream. It was neat. I've seen Dr. Gouda's bronchoscopy suite, and Dr. Nicholson sounds like he's got a pretty good bronch suite. Ours has not been updated yet. And so our comfortability for what we have for our navigational bronchs, I'm always kind of on the fence on. So if I get a negative biopsy from a nodule and the lymph nodes are negative and the CyPath is positive, I have a more stronger clinical indication that, especially if it's high risk, to actually go into resection or talk with radiation oncologists sooner than later. And it's just kind of an added, for me, is a downstream piece. So and then knowing that, well, was it truly negative or was it truly positive, and it was truly a true negative. And so there's some upstream value to it and some downstream value with respect to these nodules in terms of biopsies.
Absolutely. As far as in my practice, patient stigma was a big deal. COPDers blaming themselves and not really want to pursue it. So the fact that CyPath could be mailed to them privately in their home, and they didn't have to travel. It could be done at their own time and their own pace. That was a big deal. And you touched on something very important, that it's a data point that each clinician can add to their armamentarium when talking to patients to relieve anxiety and relieve fear, because there are mixed messages. Dr. Google is alive and well, and a lot of patients will come in having consulted Dr. Google, and so having an additional data point with a high sensitivity, 92%, negative predictive value, 99% for nodules under 20 millimeters, really helps in these discussions and quells anxiety and fear. Dr. White, would you like to talk about your case?
Well, this guy's a kind of a classic patient. He's 68 years old, still smoking. He was referred by a primary care doctor for coughing up blood. Primary care doctor treated him some antibiotics and some steroids. He was such an active smoker. He was smoking in the parking lot when I walked in to see him coming from the hospital. Um, Smoker, coughing up blood, but between when he saw the primary care doctor and saw me, his bleeding had stopped. I kind of this kind of stoic kind of guy. Just leave me, I'm just, I don't want to be a problem to anybody. Just, I'm happy just being who I am and just leave me alone kind of attitude. Wife was there. She was kind of worried. He didn't want a biopsy, and he was listed in a CAT scan in 3 months. Well, the CAT scan to me screamed cancer. He looked like he had cancer, still smoking on top of cancer. And I was like, we can do that, but let's do a CyPath that if it's positive, then we can kind of talk about biopsy. If it's negative, we'll watch. And so he was okay doing that. Sent it out. Came back. It was positive on the CyPath. We biopsied him. Stage 1 cancer. He's gone under resection at this point. He's doing well. He's still smoking, but we're just watching for new things to grow at some point. But he's done well with this. But this encouraged a reluctant patient to actually get something done that needed something done.
Dr. Nicholson, I think you have an interesting case also that you'd like to discuss.
Definitely. And I know Dr. Downey and I have discussed many different cases and utilizations of CyPath. And actually, a couple days ago, not a case I was planning on coming here to talk about, but something that struck me as so interesting. And I was so happy that I had the ability to use CyPath now when before I would have not known what to do in this situation. And it's actually a patient who is currently being worked up for a heart transplant with obviously severe heart disease, not someone you want to put under general anesthesia. And throughout the workup, former smoker, had a CAT scan done, showed a 6 millimeter nodule, plop right in the middle of the right upper lobe. IR can't touch it with the TTNA. Doesn't look like a great airway going to for a navigational with someone with my experience. And obviously someone you don't want to put under general anesthesia. And heart failure is saying, like, we need to know about this nodule before we pursue doing a heart transplant on this patient. And I was like, well, what if I told you I could send a sputum kit to the patient's house and they could do a non-invasive diagnostic test with a 99% negative predictive value? And it was just such a unique situation. Obviously, most of us are not going to encounter something like this really frequently, but I want to kind of add that unique perspective of something that came up, and also about how simple it is to do. There are so many things in healthcare now. When you tell the patient you have to get this test, you have to get this product, they have to make phone calls, their insurance, they have to schedule appointments. It's difficult. And CyPath, I tell them, the company's going to contact you. I'm going to fill out the paperwork. They're going to send it to you. They're going to call you and instruct you on how to do it. and then they're going to come pick it up from you and bring it back to their lab and send me the results. And the patient's like, so what do I have to do? So you have to answer the phone and you have to give us some sputum. And they're really relieved to see something so simple that they can do. And especially a patient like this who has all the anxiety going on of doing a heart transplant evaluation, to have something that's so easily accessible and valuable is really phenomenal.
I did receive a question just now to go over some of the statistics of our clinical trial. So our clinical trial for CyPath Lung was published, peer review published, and we reported a 92% sensitivity, a 87% specificity. We provide data as a binary, either likely or unlikely. And this is based on our negative predictive value, which for nodules less than 20 millimeters is 99% positive predictive value. So we have a very robust clinical trial demonstrating, I think, best in industry sensitivity area under the curve of 89%. And specificity, as well as the positive and negative predictive values. And as you know, everybody's prevalence in regional United States is slightly different. And that's why the negative and positive predictive values are so important. The next question is, what are the biochemical markers of the CyPath test? Can you please elaborate a bit more on what it looks like and how it detects malignant cells? So the reason I became interested in CyPath lung testing was my background in photodynamic therapy, which uses porphyrin biochemistry as its core technology. So we're a diagnostic test, a supplement diagnostic test that uses sputum, which goes through flow cytometry, which is AI machine driven for amplifying those results. There are basically four main data points that go into our algorithm. We incubate the sputum and porphyrin, which stains the malignant cells. We identify pulmonary macrophages with receptor stains, so we know we're getting a good lung sample. We filter every sputum sample that comes in that gets rid of debris. We identify apoptotic cells, which we found extremely important for the flow cytometry. And we also special stain immune active inflammatory cells within the lungs. So it isn't just the cancer cells we're looking at to give us our likely or unlikely diagnosis or probability. We are also looking at the microenvironment within the lung. And you can imagine that the small tumors are producing a unique immune response that we'll be able to see in the sputum. And so these four data points, the macrophages, the immune cells, the tumor cells, and the apoptotic cells, are assessed in flow cytometry and gives us our results. So I hope that answers that question. The next question is, what patient populations have you found that CyPath may be more likely to give false positive results in, or in what situations would you not recommend using it? That is an excellent question. We have a huge study that we've started with 2,000 patients, and I think we'll better answer that when that study is at completion. But clearly, what we see for the negative predictive value is we had an interesting case where someone had florid thrush. And that sample, it turned out to be unlikely. And then we realized in our lab that all of the patients, when there's a heavy population of yeast, we were getting negative values. And we realized that the yeast was blocking the gating in the flow cytometry. So now that is one of our exclusion criteria, active thrush. And so I think we're going to find more and more about what we need to exclude and include as we go through our bigger study. The positive predictive value of 61% is very competitive. It's comparable to the Cologuard test for colon cancer, and certainly stands up to imaging mammography for breast cancer. So even though that sounds like a weak number, it's actually very predictive. And I do think, again, the bigger study will show some of the reasons for positive predictive value being at 61%. One of the questions that I have not answered asked about why sputum, why not blood or some other mode of or direct biopsy. So the great thing about the CyPath lung test is that it's a real-time cancer test. It is looking at the microenvironment of the lung at that time that the sputum is produced. And so when we say that something is unlikely or likely in our binary result, we are talking about real-time changes that are occurring in the lung. So you can use this in patients that have had previous cancers anywhere in the body, previous lung cancer. Unlike blood tests, which have echoes of the cancer floating around as proteins in the blood, and usually these tests restrict, cannot be used whenever there's been a cancer within 5 years, including lung cancer. The real-time exam of the sputum, I think, is a huge benefit that favors sputum analysis over the blood, and obviously not compared to going in and biopsying. The risk in a bad lunger of a percutaneous needle biopsy or even a robotic biopsy is tremendous. And we haven't really talked about the finances yet of these high-end robotic procedures, but it is a very expensive test, and we're in an era of financial crisis and trying to figure out the best use of our money. And so having a cost-effective test like CyPath as compared to going after a low probability nodule with a very expensive test just, I don't think, makes sense to me. So I have two more questions. The algorithm that CyPath Lung has developed, and I'm going to walk through it as I answer the two questions, which one was about the Ohio River Valley, Indiana, and Cincinnati, and histoplasmosis, and the fact that probably 90 to 95% of CT scans of patients over 60 will have pulmonary nodules. The negative predictive value for nodules under 20 millimeters being 99% in our clinical trial. That is a huge positive when you want to talk to your patient that has these small sub 2 centimeter nodules, probably sub 1 centimeter nodules in these high endemic areas of fungi. You can go by society recommended CT scans if you do a CyPath, and it's unlikely because the negative predictive value is 99%. That is a very powerful test.
Hey, Dr. Downey, I have a bunch of histo out where I'm at as well, and I haven't seen any problems in terms of the CyPath having a bad results in the histo. I see a lot of histo out here.
Yeah, the Red River Valley also is an endemic area, absolutely. And then there was a question about what is the smallest size. Well, I'm going to go and talk about surveillance. I think we have utility, and we've shown utility in radio occult disease, having negative predictive value and a positive predictive value, even in radio occult disease. But Clearly, there is utility in the sub 10 millimeter all the way down to 6 millimeters. I have personally used it in 5 millimeters and 4 millimeters with success. And maybe the panelists, have you used it as small as 4 millimeters?
Absolutely.
Yeah. So I think 4 millimeters is probably a pretty good cutoff for its utility. If you go below 4 millimeters, all of the pulmonary nodule calculators don't even, bother with a probability. And I think you can follow society guidelines for follow-up CTs at that point. The algorithm that we're suggesting, and I'm going to start by giving the disclaimer that says the provider, the patient conversation and the clinical experience outweighs any data point. I mean, in the end, as a clinician, you will have a gestalt. You'll have a feeling about that nodule based on your clinical experience and your clinical wisdom, and that trumps so many any data point that we can come up with. But that being said, I particularly find if you have a patient that's at high risk and they have a low dose CT scan and you're sub 15 millimeters, so the right hand side of our algorithm, you get a CyPath test. If the CyPath test is likely, then even though this is a small nodule, the positive predictive value is 61%. We're going to recommend in our algorithm a biopsy. But again, clinical gestalt might say, well, positive predictive value of 61%, that means that 39 times out of 100, that will be a false positive. If you have a likely result and it is in a smaller lesion, can you wait and do a follow-up CT scan, or should you go with a biopsy? Maybe one of the panelists can comment on that.
Our practice is to biopsy. So the smallest lesion I've ever biopsied was 4 millimeters for metastatic cancer, and that patient did receive a CyPath and it was positive. That's why we biopsied. So 4 millimeters is pretty small, but we have done a biopsy of it with successful results. So in our practice, we can get after those, and so we perform a biopsy on those patients.
I think at this point, we've caught up on questions. I would like each of the panelists to kind of summarize their thoughts. We'll go in reverse order. Dr. White.
Well, I'll just state what I like about CyPath. It's an easy test. It's pathology agnostic. It doesn't matter. It's a squamous cell adeno, breast cancer, prostate cancer. It's whatever malignancies in the lung. Gives lots of peace of mind to the patients if it's negative. It encourages me that we should probably biopsy or watch it more aggressively if the CyPath is positive. I've had patients get procedures that they didn't want it. I've had patients not get procedures that they wanted it because the CyPath was negative. It's a good clinical decision tool to use. Downstream, also, again, I think there's a huge place for it too. If you do a biopsy and it's negative, is it truly a true negative, or do we need to do something different? Do we need to go to the surgical approach? I've had patients get treated for lung cancer or treated for a cancer that was a lesion that was positive on CyPath, weekly avid on PET, and is a high risk patient for any procedure. So just go ahead and do some SBRT. It's a nice, easy test that gives you a lot of clinical data.
Dr. Nicholson?
I would close by saying that when I was a fellow and a new attending, nodules were probably one of my least favorite patients to see in clinic. I was constantly stressed about whether or not I was making the right decision and overwhelmed by the amount of risk stratification tools that I didn't feel like actually helped me make a better decision and didn't help me to communicate with the patient. So I think having a tool that A, helps me to make the right clinical decision, and B, makes the conversation with the patient more on their level and able to tell them, like, kind of pull back the curtain and say, hey, this is the data that I'm going on and this is why we're doing this test. It's made me so much more confident in my ability to deal with these nodules in the office. And every pulmonologist that I've talked to or worked with, like I said, I have 10 who work out of my practice. I was the first to start utilizing CyPath, and every single one of them who used it once, after one use now, like incorporates it into their practice because they see how useful it is both to them as the clinician and also on the patient end of things. When you get that, while you're waiting for the next CAT scan in 3 months, you get that sigh of relief from the patient when you call them and say, hey, the CyPath sputum was negative. And they say, oh, thank God, now I won't be thinking about this CAT scan every day for the next 3 months.
Dr. Guda.
This is actually a great conversation because we're not just talking about lung screening, we're not just talking about biopsies, but we're talking about risk stratification. So where do you start? What size of nodule do you take? For CyPath, I found it reliable to be from 6 millimeters or greater, right? For those patients that have already had a previous history of lung cancer, other risk stratification modalities may not be useful because they've already had previous history of other cancers, solid organ tumors. The future is very wide. It's very bright. You can develop it in whichever way you need to, but a lot of this, to piggyback on what Dr. Nicholson said, when I was in IP training, we were the goers. We were walking around with a scalpel, a figurative scalpel in our pocket, right? We're trying to go in and do the biopsies and do the biopsies and do the biopsies. This tells us when to not, which is great, because when you can tell a patient, like Dr. White said, your chance of you having a negative test from a biopsy is very high based on this other test that we have done, based on the sputum that you have given us, not some arbitrary number based on age or your height and your weight and what the nodule looks like. It's a much more reliable tool, in my opinion, that when you're having that conversation with people. So we use it. I mean, I ordered it a couple of times just today on patients that have 6 and 6.5, 7 millimeter nodules, and they have history of other cancers. It's not really looking like a full nodule, like a ground glass nodule, and I'm expecting it to help me make a decision whether I go after that and perform a biopsy or not. Can we do the biopsy? Sure. Should we? It answers that, should we?
I'd like to thank the audience for joining us and the excellent questions. I'd like to thank our panelists who really have given insight. I will mention that Dr. Nicholson has done a wonderful View Medi talk on the CyPath test, which if any of you if you can follow the View Medi, it is very informative and very complete. So thank you, panelists, and thank you, audience, for being involved tonight.
To learn more about CyPath Lung, read our peer-reviewed studies and journal articles, or view the patient case studies mentioned in this podcast and many others, please visit www.cypathlung.com. If you're interested in ordering CyPath Lung for your patients, you can email us at dc@bioaffinitytech.com. That's dc@bioaffinitytech.com. Thank you for your interest in early lung cancer detection.